A very good afternoon to all. So I'll be discussing about the case series of unusual headaches in children. The slide does not move. Headaches are a very common and disabling problem for children and adolescents, and 60% of the children experience at least 3 headaches per year, and similar trend is seen in India as well. The commonest cause being migraine and tension type headache. Headaches in children are frequently attributed to benign causes. However, persistent or atypical headache warrant a deeper evaluation. So this was a case of a 5-year-old child who presented with holocranial headache, increased in frequency since the past few weeks. He had occasional vomiting, unusual episode of crying due to headache, and he had consulted a pediatric neurologist who started him on treatment, after which the headache reduced in intensity. So when he presented to us, the visual acuity was 6.6 N6, pupil color, contrast, anterior segment and fundus was normal. After 20 days, the child's headache worsened again, and at this visit he presented with early disc edema. And you can note here there is presence of subarachnoid fluid on B scan. He underwent a neuroimaging where a large cystic mass was noted in the left temporal region, suggestive of an arachnoid cyst. He underwent a left temporal mini craniotomy and endoscopic fenestration of the arachnoid cyst, and there was resolution of the subarachnoid fluid. This was a case of a 14-year-old child who came with holocranial intermittent headache since 2 years, which relieved after rest, and there were no aggravating factors. Her visual acuity was 6.6 N6 with mild compound myopic astigmatism. Pupil color, contrast, anterior segment and fundus was absolutely normal. The child was prescribed glasses and was advised to consult a pediatric neurologist if the headache persisted. However, to our surprise, she comes back again after 3 weeks with sudden drooping of the right eye upper lid. Her visual acuity was 6.6 N6 with right ptosis, left face turn and anisocoria, where right eye was a larger pupil. Her cover test was suggestive of a right third nerve palsy involving the pupil. Again, a neuroimaging was done, and it was noted to have a large craniopharyngioma which was compressing the right third nerve. Her visual fields were absolutely normal. The RNFL was normal. However, the GCC showed early binasal thinning, suggestive of early chiasmal compression. She underwent decompression procedure, following which the third nerve resolved completely. This was a case of a 16-year-old female child who came with holocranial headache which had increased since the last 1 month. She was a known case of migraine since early childhood, and this visit she described that her headache was something unusual from the previous headache that she would get. The visual acuity was 6.6 N6, pupil color, contrast, anterior segment and fundus was absolutely normal. She was referred to the neurologist in view of the unusual headache, and incidentally on neuroimaging was noted to have a pituitary macroadenoma, which was a pituitary macroadenoma. Her visual fields were normal again. The RNFL was normal here, and GCC showed early binasal thinning, again suggestive of a chiasmal compression. So what are the important aspects of headache that we should be aware of? We should know what is the onset and duration, whether it is sudden in onset or progressively worsening over time. The location and the character of headache is very important, whether it's severe or unusual pain, especially in the occipital or bifrontal region. The triggering factors and the timing, like morning headaches, nocturnal awakening, aggravation with activities like coughing and bending, any associated symptoms like nausea, vomiting, visual changes, neurological symptoms, and if the daily routine activity is getting disturbed, like child is missing school, if there is any sleep disturbance or inability to perform routine tasks. One should be aware of certain red flags that you can see along with headache, like systemic signs and symptoms like fever, weight loss, neurological signs like vision loss, cranial nerve palsies or ataxia, occipital headache in high-risk groups, postural headache, headache in very young children, headache associated with infective signs, squint or papillary edema, waking up from sleep or early morning vomiting or thunderclap headache. We know that MRI is the imaging modality to look for any secondary intracranial cause. However, ophthalmic tools like OCT, visual fields and B-scan also help in clinching the diagnosis early. So what are the lessons that we learn from these cases? So there's a need for a close follow-up, reevaluate persistent headache at least within 1 to 2 weeks. Intracranial compression can present without any alarming red flags, so close follow-up is very important in persistent headache. Pay close attention to patient's description of headache, and timely referral to the neurologist is a must. So I would like to conclude by saying persistent or unusual headaches need more attention. A comprehensive approach is very important. Recognize red flags, utilize advanced imaging techniques which can help to clinch the diagnosis early. Timely intervention will improve the prognosis and reduce long-term complications. and a collaborative effort and awareness among clinicians is a must to treat these children effectively. Thank you.